So this session we're going to talk about, is the molecular testing going to be more confusing or is it going to be of added value? So Professor Fred Tenover, who's been vice president before with Cepheid, now actually professor at Dayton University, his old alma mater, is going to help us and sort of put some meaning to this. So Fred was already an authority 30 years ago when I was still doing my residency in Erasmus in the Netherlands, so he was already quite a hero for me at the time, and it's a great pleasure for me now to chair the talk of Fred. So Fred, the floor is all yours, and I look forward to hear your wisdom.
Well, good morning, everybody. I am delighted to have this opportunity this morning to share with you some thoughts about the future of clinical microbiology. Not the distant future, but really the near future. So I don't have any corporate relationships to disclose at this time. So let's talk about the goals for today. I really want to explore with you the end result of what we seek with novel molecular diagnostics, such as host response markers. I want to explore then the results of new tests that are going to create more value, or are they potentially going to cause a lot of confusion? And I'd like to explore the comfort level of microbiologists reporting out probability results as opposed to organism identifications. And then last, to explore whether your laboratory in particular should be on the cutting edge of using these new technologies, or do you want to wait until you consider it to be more well established? Well, I'm going to talk a little bit about teleology, not teleology, but teleology. So teleology is the study of the ends, or the purposes. Why are we doing what we're doing? And we look at something by looking at the results and then going backwards. So today we have to ask the question of really, what's the impact of molecular diagnostic end results on patient management? Is that result going to be a probability as opposed to an organism identification? And how are our physicians going to deal with that sort of a result? So after many, many years of presenting, I can tell you this is not how you start a presentation. You get this sort of response, or you get this response. Yet, it's interesting to me that bioinformatics is now really critical to a lot of novel molecular diagnostics. You think about whole genome sequencing, you think about metagenome sequencing analysis, think about host response markers, artificial intelligence and machine learning algorithms are really at the heart of a lot of our new diagnostic tests. In fact, we're already reporting out a lot of bioinformatics results. And the question is, do we really understand those results? I mean, when you report out something like Enterobacter hormetii subspecies steiger-walti, and then genotypes and associated antimicrobial resistance markers based on genome sequencing or K-mer spectra analysis, do you really understand the accuracy of those results? Or are we just taking it on faith that these new algorithms are working very, very well? So bioinformatics is really part of what we do now. I think art is actually a better starting point for a lecture. We love to look at pictures like this. Yes, absolutely. But while we're comfortable looking at the end result, the fact that it's pleasing to the eye, do we really understand what the artist meant to convey by his or her work? And with that in mind, I'd like to explore a painting by Joaquin Sorolla, who is a Spanish artist. The title of the painting is The Sad Inheritance. You can see a number of young boys here, and they're being overseen by a very kindly monk. They're all crippled. They're playing at the seashore. And in the year 1900, Joaquin Sorolla's painting won both the Grand Prize and Medal of Honor at an art exhibition in Paris. The painting was very, very widely praised. The painting won another medal at the National Exhibition in Madrid a year later and went on to be nominated for the French Legion of Honor. Now, Sorolla's social commentary was the focus of this painting, and it was the idea of the immoral marginalization of disabled children. They were called the dregs of society. that society has thrown from its bosom. They were the saddest waste due to their sad inheritance. But what was this sad inheritance? Well, understanding the painting a little better shows us that it was the parents of the boys who he believed had contracted syphilis from immoral sexual activity that passed it then on to the boys, leaving the boys with lives of pain and suffering. The presumption was that all of these boys suffered from congenital syphilis, and that was widely accepted at the time. But his painting was based on an inaccurate diagnosis. The children he painted were indeed outcasts. They were the dregs of society, but according to 21st century neurologists and orthopedic surgeons, the painting depicted the boys were suffering from polio, not syphilis. The title of the painting, we know now that polio was in fact very common in Valencia during this time, but the disease was unknown both to science and medicine. So they presumed it was syphilis, but in fact that was an incorrect diagnosis. So again, the artist's purpose was social commentary and to draw the attention to the plight of these children who had been cast aside by society. And he was very successful. As a matter of fact, there were a number of programs that were instituted to deal with these poor children. He brought the idea to the public's attention very successfully. Now, does the fact that he got the disease totally wrong make a difference? Since the end result is what he wanted to achieve. So, now turning to infectious disease, let's consider some of these novel methods we're using of diagnosing infections in terms of getting to the right end result we want to achieve, and that is selecting the appropriate anti-infective therapy and optimizing patient outcomes. We're changing the process. If we diagnose the presence of an infection rapidly, but we do not identify the specific pathogen, as we do with host response markers, can we still achieve our endpoint in selecting appropriate antimicrobial therapy and optimizing patient outcomes? Now, from the antibiotic stewardship perspective, I think the answer is perhaps yes. But if that answer is a probability with a moderate likelihood, are we still going to achieve that end? Can we enable stewardship, or are we going to just generate a lot of confusion among the end users of that information? Well, if we think now about the goals of traditional clinical microbiology, we attempt to identify the cause of an infection or an infectious process through culture and other diagnostics. If an organism is identified, we then provide antimicrobial susceptibility testing information for that bacteria or potentially a fungal agent. We then use that information to optimize therapy, applying antimicrobial stewardship guidelines, and hopefully we then discharge a healthy patient. Now, we might think about updating those goals. So let's start with determining if there is an infection present rapidly using host response markers and biomarkers. We now initiate therapy based on the rapid results that we've obtained. We now identify the cause of the infection or the infectious process. We provide susceptibility testing data for the bacteria or the fungus. And now we adjust our therapy based on antimicrobial stewardship guidelines. So we have changed the paradigm in a manner of fashion, and hopefully again, we discharge a healthy patient potentially much faster and with fewer adverse events than with the traditional pathway. So we have upgraded the outcomes potentially using these types of tests. Now, clear pathway or confusing the issue? Well, let's look at some data. So I want to begin with this article that was done by Tim Sweeney and Professor Khatri a number of years ago, where they were one of the first groups to really look at a wide variety of biomarkers and then do this algorithm where you start with a patient who's got an acute illness, you then determine infected versus non-infected, and then you determine if it's infected, is it bacterial or viral? And in this paper, in this study, they really showed the potential for this sort of diagnostic test. Unfortunately, it really sort of ignored fungal and parasitic infections early on. But we get this rapid read of infected or not infected. And is the infection present? If so, is it bacterial viral? So now, does the use of these host response markers and biomarkers to determine the presence of an infection rapidly improve patient outcomes versus the traditional diagnostic methods and potentially reduce adverse events? That really is the critical question that we need to pose to ourselves. Does the information on disease severity and prognostic information really improve care? Because now we're just not identifying infection, we're saying, how is that patient going to fare? Are they going to do well? Can we make that outcome better? So I'd like to talk now about a novel electronic health record embedded software program that uses some unconventional biomarkers and clinical data together. So we're using some new diagnostics and we're pulling information together out of the patient medical record to predict sepsis. So we've got 22 individual biomarkers and patient parameters to give us this predictive information about the presence of an infection and the progression of sepsis within 24 hours of the assessment of that patient in the emergency department or the hospital setting. So that's where we're going to go with this particular study. And the study is going to use software to generate a risk score into 4 discrete categories. So the patient will be assessed, and they will be put into the category of low, medium, high, or very high risk of sepsis and ability to prognose that infection. So we're looking at in-hospital mortality. We're looking at the need for escalation of care within 24 hours of that ICU admission. So here's an example of you take all that information and what you generate now is a score. In this case, that score is 92. So very high. So this patient has a very high risk of sepsis. They have a poor prognosis. That's the information that you're getting really early on in this particular study. Now, I will tell you that this particular algorithm has now received authorization from the US Food and Drug Administration. So this is not so much in the future, this is something that could be put into practice now. So just to give you some of the data behind this particular submission, you can see here, again, we're talking about the septic patients. So you have a no sepsis control in the left-hand side, then you have sepsis, and then you have septic shock. And you can see that the score goes up in a statistically significant way when you progress from sepsis to septic shock. Now, in another group of population, another population that did not have sepsis, but had either organ dysfunction or an infection, we look at the same progression. And you can see we've got the control in the lower left half of that where there is no organ dysfunction and no infection. Then we move to infection, then we move to organ dysfunction, and then we see both. And again, the risk score goes up as you progress from no dysfunction, no infection, to having both. So this particular algorithm seems to work. And if you look at the area under the receiver operator curve, you can see that in those patients who were discharged that had a low score in the green arrow, they were much less likely to progress to sepsis. In other words, they got out of the hospital early versus those that had a higher score. So in this 50% discharged fraction of patients in this study, there was a significantly higher proportion of people who were discharged who were in the lower risk category group, which suggests that this particular assay, this algorithm, does in fact work at predicting how patients are going to fare. Turn now to another example for you to consider. This deals with community-acquired pneumonia, looking at a novel diagnostic test. And here we have looking at a host response test to diagnose community-acquired pneumonia. The test measures serum levels of 3 key host immune response proteins, tumor necrosis factor, and 2 others, including CRP. Their levels are integrated using a machine learning algorithm, again, into a qualitative score, indicating viral versus bacterial infection. So if that score from this algorithm is 0 to 35, it indicates viral infection. If it's 65 to 100, it indicates a bacterial etiology. If it's in the middle, 35 to 65, it's considered indeterminate and you need other diagnostic tests. So I want to focus not so much on the quality of the study, but the concept of what you as a clinical microbiologist would be reporting, or what you as a clinical infectious disease person or the pharmacist working with this patient have to deal with. So as you can see here, you've got 0 to 35 or 90 to 100. Is that really what you would implement in your hospital? In other words, is 10 to 90 the real equivocal range? Is that what you would feel comfortable with? Perhaps when you do your in-house validation study, these are the results that you would be comfortable reporting. And as you do that validation study, maybe that equivocal range gets tighter and tighter and tighter. But again, as clinical microbiologists reporting data, this is something new for us. It's not an E. coli susceptible to ciprofloxacin and ceftriaxone anymore. We're working earlier on the diagnostic pathway. We're trying to get that rapid result. We're trying to optimize therapy faster in order to do the patient better in terms of outcome. One other example of this, here's a test that was designed for the triage of COVID-19 patients. Basically, you again generate a test score, a severity score, something that's going to give you a prognosis of how that patient's going to do. And as you move through the categories of this patient has mild illness, to moderate illness, to severe illness, to this patient is critical, you can see that for almost all of those, there is a statistically significant difference in the ability of this test to predict those categories and look at those patient outcomes. So practically speaking now, again, if you were to implement this in your laboratory, the question is, how do you deal with those categories? What is the management of a patient who has mild versus moderate, or moderate versus severe, or severe versus critical? How do we introduce this into our patient practices in our hospital? Are we adding value early on to the management of the patient, or are we adding confusion to our clinicians who are trying to figure out what this means for the actual management of the patient in your patient population? Now, once again, traditional clinical microbiology asks 2 simple questions. What's the pathogen, and how do I treat the infection? This has been our focus for many, many years, but that focus now, I think, is changing. So we're going from an algorithm where we collect a specimen, we perhaps do that gram stain, we do a culture, we identify that culture, often using an automated method or maybe MALDI-TOF. We generate the susceptibility testing information. We issue that report to our healthcare team, or alternatively, what we do is we collect a specimen, we test that specimen in real time, either at the point of care in a central laboratory. We now report out that information in an hour or less versus 2 to 3 days. We've definitely impacted the management now, but can we go even better than this on the diagnostic pathway? Now, when we look at multiple studies on the use of rapid diagnostics on bloodstream infections, basically the data say two things. Number one is, if you use rapid methods and you have an antibiotic stewardship team in place, then the patient is going to have a better outcome. If you generate a rapid result and you don't have a stewardship team, it's right on the borderline of being significantly better. But when you take all those data together, yeah, having a rapid diagnostic has a positive impact. You improve outcomes when you use rapid diagnostics. So we've already put that in place. We've got that part of the diagnostic pathway pretty much assured. But now we have to think about this new diagnostic pathway. We collect the specimens, we send them to the laboratory, we do host response markers. We try and determine very quickly, is it bacterial, is it viral, or is there no infection? We give that information to the healthcare providers now to make that rapid assessment. And again, we're using biomarkers, we're using patient parameters, we're using this to predict the progression of things like sepsis within 24 hours, or community-acquired pneumonia, or other infectious processes. So this is sort of the new upfront pathway that we really need to consider. And in contrast to culture or PCR results, these results are probabilities. They're risk scores. So this was a great article by Mezakar and colleagues, and it asks the questions about not antimicrobial stewardship, but diagnostic stewardship. How can we be the best, the most reasonable stewards of our laboratory information? And number one on the list is the right interpretation. Will the clinician understand the test result? That's really the critical thing we need to be thinking about now. How do we communicate this new information, particularly if we can show that, yes, it has a very positive impact on patient progression? So, in the age of host response, first, is there an infection present? Then, what type of infection is it? Is it bacterial or viral? Or hopefully, in the future, fungal or parasitic? What's the prognosis of the infection? So now we're going beyond just the here's what it is and here's what it's susceptible to. It's how sick is this patient going to be? What's the likelihood that they're going to recover? So once again, though, these tests are in addition to the rapid molecular tests that we're doing now. It is in addition to culture, which we haven't gotten rid of, so they are going to be definitely more expensive for the laboratory. They are in addition to those things that we're already doing. So you really have to be thinking about, are we getting into information overload now for our clinicians, or are we truly providing a better way to manage our patients? Information overload? Not if the tests are instituted with the appropriate consent of all stakeholders. Not overload if they're preceded by an educational program for all the stakeholders that demonstrate their value. Not if they're appropriately validated in-house prior to their use. And not if the reimbursement issues have been adequately addressed. So there's a fair number of not ifs there, but the potential, I think, is very, very strong. So the bottom line for all new diagnostic tests is this: is the juice worth the squeeze? Now, what laboratory should be performing these new molecular tests? I think we have to consider laboratory expertise and then look at their time to adoption. So you can think about the fact that, and we all know these laboratories, there are pioneer, just visionary laboratories that are coming up with wonderful new diagnostics all of the time. So their expertise is high, their adoption is immediate. Then we have large academic medical centers where their expertise is high, and usually their adoption is pretty rapid. They want to be there on the cutting edge. Now we have community hospital laboratories. Their expertise is moderate, you can say, and their adoption time, pretty variable. Then we have urgent care centers, expertise really pretty low, adoption variable, and then we have physician office laboratories where it's usually low and low. So theoretically, this is the way the world works. But in the real world, and I have certainly seen this over my career in diagnostic microbiology, we have visionary community hospital labs that want to be the first in their region to adopt the new technology. They want to be on the cutting edge. They want to market the fact that they are ahead of the curve. On the other hand, we have some large academic medical centers that have very tightly restricted budgets for new instrumentations and tests, and so their hospitals don't actually invest immediately in new technologies until they wait to see how things pan out. So the question really for today is this: what type of laboratory are you in? How do you approach new technologies? These new technologies are already here. You can have the approach of I can and I will adopt. You can have the I can and I might adopt, or I can't and I won't. That's what we have to be thinking about now. So, how open is your medical staff to new technologies? How broad is your laboratory expertise to understand, implement, and validate these new technologies? How does your electronic medical record system adapt to novel tests? How does reimbursement impact test selection? What other services need to be involved in these discussions? Do you need to talk to your surgeons, your oncologists, your pediatricians, the nursing, the pharmacy, the infection prevention, the quality management people? And the answer is yes, 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 yes. You need to bring all these people to the table when you're thinking about implementing these new technologies. Now, Marty Blaser wrote a terrific paper a number of years ago called Antibiotic Use and Its Consequences for Our Normal Microbiome. It really details the impact of antibiotics on diseases like type 1 and type 2 diabetes, autism, a whole host of things that are actually directly related to antimicrobial use in ways that we probably never thought of before. It's a marvelous, marvelous review. And Dr. Blaser goes on to say that future research, based on our extensive and growing knowledge of bacterial genes and genomes, should aim to develop truly narrow-spectrum agents, each ideally targeting a single pathogen. And this strategy was going to require new diagnostic tests that accurately and economically differentiate between bacterial and viral infections among specific bacteria, and also distinguish between colonization, infection, and host-specific, indeed individual differences that may require more personalized approaches to antibacterial therapies. Now, that's quite a challenge. But I can tell you that Dr. Blaser probably did not consider the following diagnostic test when he wrote this article. So, what novel technologies are on the horizon for us to move into this new era of rapid diagnostics? Ladies and gentlemen, I give you the diagnostic technology coming to your bathroom. This is a real product. This is called the TrueLoo. It is a toilet that can actually detect in real time things like urinary tract infections, kidney issues. It has built-in chemically activated tests. It is, if you will, smart toilet technology. So simply by sitting on the TrueLoo, you can securely record and upload data, and you get no need for other information from the resident. Effortless health monitoring with every flush. Sounds silly? Yeah, but it works. So, clinical microbiologist, ID colleagues, pharmacists, this is in our future. This company in San Francisco is already selling these. How do we react to this? Okay, this is a little further out than host response markers, but not that far out. But the challenge is to us. How do we integrate these new technologies? So should your laboratory be among the first, really, to engage these new technologies? The teleologic view says we examine the end result to evaluate the process. We look at the end result to evaluate the process. What matters is ultimately discharging a patient who has fully recovered from their illness. So, can we speed up that process? Can you improve therapy early on? Can you avoid doing other unnecessary tests? These technologies we've talked about may answer these questions and optimize patient management by using a whole new diagnostic approach. So let me sum up then. The state of infectious disease diagnostics is evolving very rapidly, driven in part by host response markers, prognostic assays that use artificial intelligence, and machine learning. Host response diagnostics are, in fact, the next wave of laboratory testing, but reporting probabilities of infection and prognosis are novel concepts, both for the laboratory and for the clinician. Each laboratory, each infectious disease service must decide soon when and what their level of engagement with these new diagnostic tests is going to be. There is indeed, I think, much to consider. Discussions should seek to be inclusive, to optimize all aspects of patient management to improve outcomes. So I think you ought to be the pioneer. Engage now. Be the teleologist, if you will, because it's the end game that really counts. Thank you for your attention.
Thanks, Fred, for all this food for thought, from taking us from the arts to communicating your rapid results. Otherwise, it's meaningless to good governance of your lab. So the floor is open for discussion, maybe to sort of kick it off. So what I often find is that bacteriologists or microbiologists in the world, particularly in low research settings, are sort of at the bottom of the healthcare food chain, so to say, and it's for them very difficult to sort of engage with the clinicians and are often not even accountable or don't even have a budget. So do you think, do we have to move that one, microbiology should be one, empowered and also have some budget responsibility so they're also accountable? I mean, what do you think?
Yeah, it's a great question, and really what the laboratory needs are clinical advocates that are going to go to your chief financial officers and say, to do better, we need this. So rather than the laboratory, which you are correct, oftentimes does not have that influence, you go to the head of medicine, the head of surgery, you go to the quality team, you go to these people, you build your coalition, then you go together to the chief financial officer and say, you know what, if we can get these people out of these beds faster, but cured, so they don't come back, you're going to have more beds available and you can bring in more money. So you make the financial case, but you don't make it alone. You make it as a coalition. And this can be very, very effective in allowing you to bring in new technologies. But it's better if you go in as a team as opposed to by yourself.
Suha?
Yeah, thank you, Fred, for an excellent presentation. So my question is about whenever you have a technology available in the hospital, and we saw that with COVID-19, people start using it. It's not a matter of using the technology that can help making a diagnosis. The biggest struggle that we witnessed during COVID-19 is the overuse of the molecular tests and the added budget. And and every patient who came with fever, with classic urinary tract infections, you know, had also a COVID PCR, etc. How can we convince clinicians, you know, to use these in a judicious way so that we don't overuse them and abuse them?
Right, it's a very, very important point. And during COVID, we had this problem of we didn't have enough diagnostic tests to go around from one company. So all of a sudden you were running 3 or 4 different tests because you could get tests from this company this week, but not the next week. And oh, you could get them from over here. And so now that we've come out of that, we really can start thinking about diagnostic stewardship better. And I think one of our issues for many, many years is that clinical microbiologists have not been as good educators as we need to be. We really need to engage with our clinical colleagues and develop these partnerships so that when we say to a clinician, this actually is not the best way to make this diagnosis. This is overkill. You don't need the syndromic panel in this case. What you really need is this. And then tell them why. Not just tell them no, but tell them no because. So I think what we really need to do as clinical microbiologists is engage our colleagues with data and say, we think this is the best test for this reason, and here's the article I think you ought to read. So it's much more work, but again, if you start to educate the clinicians so they order the test better, then the outcome is going to be better for the patients, and you're going to be doing less testing, but more effective testing. I think that's where we really need to focus our efforts these days, especially with these new tests. We need to understand them ourselves, but then we need to communicate that understanding and bring all of our clinical colleagues on board.
Other questions in the room? So regarding, so once you can have like a more expensive test, but then the benefits are in a different budget, like less isolation days, for instance. So how can you sort of go about it? Because often these budgets and managers are very rigid. That how can you make sort of integrated or integrate the budgets in a way and that it benefits everybody? Have you had any experience with that?
Yes. So the hospital silos are difficult to break, but that's why we need to build these coalitions of people to get around the silos, because I have clearly seen that in hospitals. Hey, I can save the pharmacy X number of dollars. Okay, well those dollars now come out of the pharmacy and go to the laboratory. And well, the pharmacy's not very happy with that. So what you need to do is when you have your stewardship teams, your diagnostic teams, it's sort of like, if you will support this, I will support you in what you need. So we have to build these partnerships and try and break down the silos. And if we see the hospitals, the visionary hospitals that develop and implement these new tests, they're usually the ones that don't have these big silos, where the chief financial officer has seen the bigger picture. And yes, I can save some money here and save here, but I can't just decrease this budget. We want these people to do well as well. And so it's the integration where you look at the big picture and go together as a team looking at the trade-offs. If you can do this for me with this new diagnostic test, I can save you money in doctors not putting every patient on a carbapenem. So that's the sort of thing we need to do, which means we all need to be educated and understand a little bit about what every department does. That way we can make our case more effectively.
So education is key, yeah.
Thank you so much for your excellent speech. This is Dr. Banu Sancak from Hacettepe University, Ankara. I actually want to learn your opinion about applying soft stops and hard stops in our laboratories. Thank you.
Could you expand on that a little bit more?
For example, for Clostridium difficile infections, if you are using laxatives, you can warn the doctors that before they send the stool specimen to the laboratory, please don't send stool sample to laboratory because of that. This is soft stop. For example, in 24 hours, we are not expecting, we are not getting the samples from the clinics. If they send the respiratory samples for rapid test, we can stop it, we can do hard stops for it. What is your opinion about that?
Yes, so I'm a firm believer in hard stops, but only with education. So, and typically when I was running my laboratory, when we would get a specimen that we would normally reject, we put it to the side, we contact the clinician and say, we're not going to do this for this reason, unless that clinician can convince me that there's a very good reason in this particular patient to run that test. And that happens sometimes. Okay, I didn't know they had a VP shunt in. Okay, that's why you want to look for this. So again, it's the, I believe in hard stops. I believe in not doing C. diff, within a 7-day period, especially if they're PCR positive. There's a whole host of those that are part of diagnostic stewardship. So as the lab director, let me help you understand why that's not the best choice for you to do this multiple testing. But it's always with that idea of microbiologist as educator, as opposed to just saying, no, I'm not going to do it. Okay, I do know some microbiologists that way. That doesn't work very well. But if you convince that person that this is the best way, this is why we have this hard stop, then perhaps they will educate their fellow clinicians that the next time they say, oh, no, don't send that second, third C. diff, you don't need that, and the laboratory's not going to test it anyway. So hopefully that education begins to spread among the colleagues. And if we do it in the appropriate fashion, I think that actually works pretty well.
Anyone else? Yeah, one. I think. So 2 more questions, and then we're going to close. Thank you.
Thank you for the excellent talk. You mentioned that host response test's predictive value gets better with the severity of disease. Do you think, do we need to clarify the in terms of the severity of infections in order to use these tests properly? And who should do this, clinicians or the clinical medical microbiologist? And in my country, I'm from Turkey, and we scarcely reach the sufficient clinical information about patients. So what is your experience in US, how you get the clinical information about the patient? Thank you.
Yes, thank you for your question, because it comes down to a very important point, which is the validation of the test in your hospital with your patient population. Now, these tests are not going to work the same way in every hospital. If you're an acute care hospital versus a tertiary care hospital, if you are in a 300-bed hospital versus a 4,000-bed hospital, the way that you examine this test when you do your validation study, which hopefully will bring in the clinicians early on so that everybody agrees, here's how we're going to set the endpoints for this study. Here's what we're going to look at. We're going to try and define initially the really severe group and our control group. And we'll validate the fact that the test works at the 2 ends. And then we'll begin to move in to decide, is there really a difference between moderate and mild? Is there really a difference between moderate and severe? How do I want the doctors in this hospital to respond to this particular score? So that validation study has to be done very carefully. It has to be well thought out, and it has to involve all of the people, all of the stakeholders to design that study appropriately. Now, that takes a long time, but when you put in that effort, what you come up with is something that's truly going to impact patient management in a positive way. So that's how we need to deal with these issues of what's moderate, what's severe, because it's what's moderate and what's severe in my hospital, in my patient population. So put in that effort up front, and I think then your test will be successfully used, and we'll see positive impacts on getting more patients out of the hospital faster that are cured. Thank you all. I really appreciate your attention.
So, thanks, Fred, and also on behalf of ISAC for all your work for ISAC and being on the board. So, thank you.